Hello, everyone. Thank you so much for joining us today. I'm just going to hold for a couple of minutes and allow people to sign on. Okay. Thank you so much for joining us today. Today is the second session of the Culturally Competent Learning Collaborative hosted by the National Center for Health and Public Housing. This is the second of 4 sessions on this topic, and last week we had our first session. So if you're just joining us for the first time today, you should be able to access the slides and the handouts, and I'll describe to you later how to do that. And then for those of you that are joining us again, thank you and welcome back. My name is Saki Malik Cho, and I'm with the National Center for Health and Public Housing. The National Center for Health and Public Housing is a national training and technical assistance provider. We work directly with health centers, housing authorities, and other stakeholders to increase the access, quality of care, improve health outcomes, and health equity of public housing residents. And our Learning Collaborative today reflects the thoughts and opinions of our team here and does not represent HHS. So I just want to start off with a few housekeeping items. I did mention this last time, but just a reminder, we would like for this to be an engaging session, and there will be many opportunities for you all to engage. We have the chat open, and we are really hoping that you use it extensively. Please take the time right now, if you have a chance, to introduce yourself over the chat, add your name and organization, and why you're here, what you're hoping to gain. And then while you're listening to the content today, you feel free to add your thoughts and your questions as they come to you, so that when we get to the Q&A portion, it'll be ready. And if you see a question in the comment section, please feel free to add your thoughts as well. Just a reminder, when you do add your information to chat, just make sure it's going to everyone, so that everybody has the opportunity to see it. You can also raise your hand if you want to make a verbal comment, but please mute yourself and only turn your mic back on when you're speaking. Again, just a reminder that of the contents of the welcome packet that you received by email after you registered for the Learning Collaborative, with the goals of this Learning Collaborative. And the goals are to assist health centers in the adoption of the CLAS Standards and to help providers treat their diverse patients. So again, my name is Saki Malik Cho. I'm the Director of Research, Policy, and Health Promotion here at the National Center for Health and Public Housing. I'm joined by my colleagues, Fide Sandoval, our Research Assistant, and Dr. Jose Leon, our Chief Medical Officer. Together, all of us will be covering the fundamentals of cultural competency, language access, and community partnerships. And we'll be doing that through a combination of case studies and didactic learning. The welcome packet has some of that key logistical information, like the dates and times for the sessions and the link to the registration survey. Please fill that out if you haven't done so already. And then the welcome packet also has some instructions on how to access Moodle, which is the learning management system we use here. So you can access Moodle to get the recordings, the slides, the handouts, and other resources. You are eligible to receive continuing education credits by participating in this Learning Collaborative. You have to register online and take a pre-test and then a post-test after each session. Instructions on how to register are in that welcome packet. But if you have any problems, please just let us know and we'll try and help you. Okay, so we covered a lot of material during session 1, and I just wanted to briefly recap what we covered. It was on the fundamentals of culturally competent care. So last week we talked about the rationale for developing cultural competence, the benefits to providers and to patients, and we walked through the 14 CLAS standards. We identified the need for balance between fact-centered and attitude and skill-centered care approaches. We talked about attaining cultural competency as a journey, and we talked about the framework for developing cultural competency. And we also talked about patient-centered care in terms of the role of culture and culturally sensitive treatment options, the difference between illness and disease, and the models of effective patient communication, such as the LEARN model, the BATHE model, and the ethnic model. So it was a lot of information. Again, the slides and the handouts are available on the Moodle site. Today, we're covering session 2, speaking of culturally competent care. It's going to follow the same format as last week. We'll cover some information through slides. We'll have some case study videos. Dr. Leon will provide us with some of his experience and expertise. We'll have some polls and some questions throughout that we'd like for you to comment on through the chat feature. Again, each session is divided into 3 modules, and then each module has a learning objective. So the 3 modules for this session are the importance of language access services, models to provide language access services, and then working effectively with an interpreter. The first module emphasizes the importance of language in cross-cultural medical practice and the legal requirements that are associated with being a recipient of federal assistance from HHS, which we'll discuss shortly in greater detail. So we're going to begin this section by watching a case study about an 81-year-old Vietnamese female and the issues that arise when the patient and the physician aren't able to communicate in a common language. Fide, will you please show us that video?
Good morning, Dr. Rivera. Good morning to you too, Lisa. Hello, Mrs. Lian. How are you feeling today? Good? Her stomach is still hurting, and she hardly eats much at all. Lisa, I need you to ask your grandmother if she's experienced any discharge or bleeding. Bleeding? We take good care of Grandma. We didn't let her hurt herself. Lisa, I know you take good care of her, and you wouldn't let anything happen to her. But I really need for you to ask her if she's been bleeding. She said it's only a small cut. I didn't bleed much. Lisa, did you ask your grandmother if she cut herself or if she was bleeding? I asked her if she cut herself, and it was bleeding. Lisa, that's not what I mean. I need to know if she was bleeding.
Sorry, I apologize. I think we're experiencing hearing some echoes. Are we still hearing the echo? Second.
The video is frozen.
Not if bleeding. Not if she cut herself. She's not bleeding. You can see there's no blood. No, Lisa, I don't mean that your grandmother might have cut herself, dear. I need to know if she's bleeding on the inside, you know, from here. Well, if she's bleeding on the inside, how would we know? Well, the blood would come out of her body. From where? From her private parts. I can ask Grandmother about that. Lisa, please, I need for you to be a really big girl and ask her. It's very important. Go, Salma. She said she's fine and I shouldn't worry about her. I couldn't ask her about the blood. We don't talk about things like that. I just can't. Lisa, is there someone else that could come in with your grandmother, another family member, a friend, a grown-up who could translate for her? I think our upstairs neighbor could come tomorrow.
The problem is that she refuses to eat. Her daughter Lily, my friend, cooks everything for her, but she refuses to eat. She never should have come here. This country too much for her.
I need to know if she's experiencing any vaginal discharge or bleeding. Could you ask her for me?
Oh, she's too old for that, doctor.
I'm aware of her age. Please, I need for you to ask her. It's very important. I suspect Mrs. Lian might be suffering from cervical cancer.
Bác ơi, bây giờ bà chịu đi nhà thương hay là không?
Bây giờ nếu mà tôi đau hông thì tôi phải đi nhà thương.
Bà không chịu đi à?
Không, tôi đau hông thì tôi phải đi. Nếu tôi đã đau hông thì tôi đi nhà thương.
She's not too fond of me. She thinks I spend too much time with Lily and don't leave her enough time to take care of her poor mother. If you ask me, the old crone is perfectly capable of taking care of herself.
Could you ask her if she's willing to go to a hospital?
Don't bother, she won't. She is convinced that illness is a normal part of life and that she's earned the sickness she has. She won't go in for any special treatment.
Well, could you ask her anyway?
Bà ơi, bây giờ bà phải nói không nha. Bà chịu đi nhà thương hay là không?
Nếu tôi đây tôi đau thì tôi phải đi nhà thương. Tôi chịu đi nhà thương.
I told her she has to go, but she refuses. I told her she will die if she doesn't go, but she won't listen to me. She doesn't want any special treatment.
What about for Lisa's sake? Ask her if she'll do it for Lisa's sake.
Còn cháu bà mà chết thì ai coi cháu bà chịu đi nhà thương hay là không? Bà cứ nói không đi.
Không.
I don't understand it. Why would she let herself waste away like this? And with such a beautiful granddaughter who would miss you so much? Why does she refuse treatment?
Because she's an old, stubborn woman.
Well, this is going well. Now what?
Sorry, I'm trying to share my screen again. Okay, thank you, Fide, for showing us that video. And I'd like to go to Dr. Leon here and ask him, how would you handle this situation if a neighbor was interpreting for you for one of your patients? And have you ever been in this situation?
Thank you, Saki. First, I believe that there are a couple of things that we have to analyze here. First is the issue of private questions or private topics that sometimes is very difficult to discuss with patients when you have a relative. And second, the issue of respecting the elderly, an elderly person when for some cultures is basically difficult, if not impossible, to ask these questions. Yes, there have been some occasions when you have to rely not on the family members, but interpreters that you have. The health centers that we work with, for instance, what they do is that they have people from the community who translate for patients, and they do not have any attachment, or they are not family members, they are not friends, and they try to keep the conversation in a very scientific way. You know, you need some responses from the patient, and you need to get those responses from the patient without the intervention of family members.
That's a good point. In order, just to support what Dr. Leon was saying, in order to have an effective medical encounter, there has to be a mutual understanding between the provider and the patients. And in the case study that we just saw, there were a number of troubling concerns because Mrs. Lean and Dr. Rivera couldn't communicate effectively. So the physicians at OMH who helped develop this curriculum agreed that providing language access services is a critical component of good medical practice, because when a healthcare provider can't communicate effectively about disease and treatment, or if a patient can't describe their experience or their illness, then it's very difficult to negotiate appropriate care. And you know, the truth is that even if the provider and the patient speak a common language, it wouldn't necessarily lead to cultural understanding, because speaking different languages in a healthcare encounter can be lead to confusion. It can affect the quality of care, the treatment decisions, understanding, and compliance. So addressing language barriers can reduce that potential harm that comes from critical healthcare information not being communicated correctly, and it contributes to greater patient satisfaction and adherence to treatment. So the 4 language access services standards that are outlined in the CLAS standards, these are mandated for all healthcare organizations that receive federal funds, and they're based on Title VI of the Office of Civil Rights as they pertain to language access. Just note that we have synthesized these standards somewhat to cover the key points during this session. And you can refer to your CLAS standards handout to see the full version of each of these standards. This was in the handouts for session 1. So the language access services that CLAS standards seek to reduce language barriers and improve care. So essentially, services must be covered, offered at no cost. Patients must be informed of their right to these services. Health centers must ensure that the language assistance that's provided is accurate and that materials and the signage are translated. In 2003, the Department of Health and Human Services, or HHS, revised its guidance on providing services for people with limited English proficiency. So the guidance states that the failure of a recipient of federal financial assistance from HHS to take reasonable steps to provide persons with limited English proficiency with meaningful opportunity to participate in HH-funded programs may constitute a violation of Title VI and HHS's implementing regulations. So just let me clarify what this means by giving you a few more specifics. All recipients of federal financial assistance from HHS are required to provide to persons with limited English proficiency meaningful access to their programs and activities. And that includes those who receive money from federal grants must provide language access services. Those who receive training, use of equipment, donations, or surplus property and other assistance must provide language access services. Subrecipients, when federal funds are passed through one recipient to another, they're also covered under the guidance. And healthcare providers who only receive Medicare Part B payments are specifically excluded from the guidance. Coverage extends to a recipient's entire program or activity, even if only one part of the program is receiving federal financial assistance. Because federal funding of healthcare is pervasive, the requirement to provide language access services applies to many different types of healthcare providers. And I mentioned the term meaningful access. This is important because of the new Office of Civil Rights guidance. It states that there are 4 factors to balance when assessing the obligation to provide language access services. The intent is to suggest a balance that ensures meaningful access by patients with limited English proficiency to critical services, while not imposing undue burdens to small businesses, small nonprofits, etc. So this means that as a starting point, you can consider these 4 factors in determining the amount and the type of services that you provide. And applying this 4-factor test to the services that you already provide may help you determine that you need different or additional language access measures, or that you have already taken the reasonable steps necessary to provide appropriate language access services. And we mentioned those 4 factors in our last session, but again, it's the number of limited English proficient persons you serve, the frequency that they visit your health center, the nature and the importance of the services that you provide, and then the resources and the costs of those services. Once you've completed your 4-factor analysis, you can develop a plan for providing language access services to your patients. And useful steps for developing that plan might include identifying individuals with limited English proficiency who need language access, determining how that access will be provided, identifying staff who will need to be trained, developing a process for training them, and identifying outcomes of the training, and then describing the process to notify patients with limited English proficiency of their available services, and then documenting a process for monitoring and updating that plan. CLAS Standards 4 through 7, which focus on language access services, will provide you with some additional information about undertaking these steps, and I'll cover these a little bit in more detail on the next slide. So let's think back to the language access services CLAS standards we just discussed a few minutes ago. As a reminder, they are offer and provide language access services, including bilingual staff and interpreter services at no cost to each patient with limited English proficiency at all points of contact in a timely manner during the hours of operation. Provide patients in their preferred language, both verbal offers and written notices informing of their rights to receive language access services. That's standard 5. Ensure the competence of language assistance provided to patients with limited English proficiency by interpreters and bilingual staff. Family and friends shouldn't be used to provide interpretation services except on request of the patient. That's standard 6. And then make easily understood patient-related materials available and post signage in the languages of commonly encountered or represented groups in the service area, and that's standard 7. At least 18 states have enacted laws that make English the official state language, but because of these state English-only laws, many organizations that receive federal funding might not realize that they're still required to provide language access services for non-English speakers. A few states have passed comprehensive language access laws to ensure that communications with patients with limited English proficiency. And I do have a list of states here, but I think it might need to be updated. So I have California, Massachusetts, New York, for example, have specific guidelines. And many more states have tied language access services to specific categories of health services. State statutes and common law rules governing professional malpractice define liabilities of inadequate communication with patients, and some examples include providers may be liable for damages resulting from treatment in the absence of informed consent, and providers may face claims that their failure to bridge communication gaps breaches professional standards of care. A provider's violation of language access laws may raise a presumption of negligence. So those are just important points to consider. Providing language access services may have financial benefits for health centers and may help accrue goodwill with immigrant and minority communities. There are some lessons learned from organizations that have benefited by implementing language access services strategies. As we talked about last week, bilingual staff is the first preference for providing language access services to patients, followed by face-to-face interpretation, then telephone interpretation. HIPAA doesn't specifically address the privacy issues inherent in using interpreters for patients with limited English proficiency. And additionally, HIPAA doesn't prohibit collecting individually identifiable health information, but it does provide guidance on using data. So again, there are hidden costs associated with not offering language access services, taking ethical and malpractice risks into consideration, taking highly paid bilingual professionals away from clinical work to provide interpreter services, canceling procedures because a patient didn't understand the instructions, or patients using the ER because they weren't able to communicate with their primary care providers. So just in summary, providing language access services is not only good for medical malpractice or medical practice, but also a legal requirement for recipients of federal financial assistance. So in the next section of this presentation, we're going to talk about some best practices for interpersonal communication and the importance of using interpreters and guidance for providing language access services, both oral and written. There are 4 learning objectives in this module. List the components of effective communication, describe the role of the interpreter, understand the characteristics and the qualifications for translator competency, and then identify effective language access services for written materials. So to set the stage for further discussion of language access service models, I'm now going to play, well actually Fide is going to play a case study involving Maria Gonzalez. So her son, Arturo, had suffered from an overdose of amitriptyline because his mother didn't understand the dosing instructions. So Fide, I think we're ready for you to play that video. Thank you.
Hola, yo quiero hablar con doctora Rivera. Doctora
You
Rivera.
don't have an appointment.
Doctora Rivera, yo tengo
No
una pregunta para ella.
appointmente.
Yo tengo una pregunta de mi hijo.
What's going on?
She wants to see Dr. Rivera, and she doesn't have an appointment.
Joan, you triple book patients as a matter of policy, and you're concerned with an open slot now? You know, her son just overdosed, and she was hospitalized too.
Hola, Maria. Dr. Rivera, see you soon. The hospital sent her over after Arturo swallowed those pills.
If you live in America, you should speak English. There should be a law.
You gotta walk in Mrs. Gonzalez again. I told you about her losing it in the emergency room the other day after her boy OD'd on amitriptyline. She was a real basket case.
Sounds like she had an ataque.
Oh, well, she had an attack, all right. Who but an Hispanic woman could get that worked up?
I was talking about an ataque de nervios. It's a cultural bound syndrome recognized in the DSM-4.
Don't get so upset. It was just a little joke.
Well, your joke isn't funny. Fostering stereotypes through humor is still fostering stereotypes. It's hurtful, and it goes on far too much in this office.
Hola, doctora Rivera. Gracias.
Me estoy volviendo loca.
No.
Mal.
Cálmate, calm down. Calm down. No te está volviendo loca, okay? You're not going crazy.
Okay.
Yo creo que te dio un ataque de nervios. It's just the attack of the nerves. It happens to anyone. Te voy a dar un panfleto que es bilingüe, right? Spanish and English, para explicarte más acerca de ese ataque, pero no te preocupes con eso ahora, okay?
Okay.
The big problem here, el problema más grande aquí es su hijo.
Sí, mi hijo.
Your son. So let's talk about his medicine. Okay, you're going to give him one pill a day, every day. Solamente una píldora al día, cada día. Es mejor que se lo da por la mañana.
Por la
in the
mañana.
morning with his breakfast, con el desayuno.
Gracias.
Pero también yo siento mal porque mi hijo está en la calle con amigos toda noche.
Okay, did you talk to the counselor? ¿Hablaste con el counselor acerca de eso?
Sí, pero ella no habla en español, solamente en inglés.
Oh, you're kidding, on English? Okay. Yo te
Yo no
voy a
entiendo.
escribir una notita aquí. I'm going to write you a little note para pedirte un counselor que habla español.
Es mejor.
So we're going to get you a counselor that speaks Spanish. Y entonces lo que quiero es que llama y hace an appointment. An appointment for you and Arturo, okay? Tan pronto sea posible.
Okay,
So
para
as soon
nosotros
as
un
possible.
tratamiento. Okay.
Ajá. Y no te preocupes. Everything's going to be fine.
Gracias. Gracias.
Okay.
Muchísimas gracias.
We'll work with you.
Thank you.
You can see my screen? Okay, great. Thank you. So Jose, I'm going to turn it over to you. What are your initial thoughts about this case study?
Well, for the non-Spanish speaking audience here, the ataque de nervios that the person referred to is just a panic attack, you know, and the doctor was clear to say that that is a diagnosis. But let's go back to the video. First, I believe that there has to be more, I mean, when you have a patient who probably doesn't speak English, first you have to have the ability to work professionally. Even if you have some kind of ideas or something that is going in your mind, you have to refrain from saying things that are not appropriate. That is part of the cultural competence pattern and learning. We saw the doctor and the person helping the doctors basically making some comments that are inappropriate. So that's something that you have to provide training to your staff when there are situations like this one. And then the need of interpreters, I mean, we saw again that even though Dr. Rivera was talking to the patient and was trying to explain all the issues, there's still the need in the organization or within the organization to provide those services in Spanish. So we need to make sure that when we have a patient and that patient has limited proficiency, then we need to make sure that the services that we offer are offered in the language that the patient speaks.
Great, thank you so much. And if there's anybody on the line that has had a similar situation with other staff that have made, you know, maybe inappropriate comments, I just want to ask any of you to offer up suggestions on how you may have handled that in the chat function, or how you might try to approach that with your colleagues to improve the cultural competency of your staff. So here are some best practices for interpersonal communication that we've identified, or actually the program has identified. The first is to understand that patients, especially older persons or persons of the opposite sex, may have different levels of comfort than you do with formality, silence, physical distance, eye contact, touching. It's better to learn the preferences of your patients and their communities. Some good practices are to be conservative in your body language until you understand what's appropriate within a specific cultural group. Listen and observe what is appropriate and comfortable for individual patients and act accordingly to show that you understand it. And don't discount the effect of beliefs about the supernatural on health, because that is very present among many different types of cultures. Learn basic words or phrases from your patient's language to be able to greet them, for example, or ask how they are feeling. And don't share bad news or complications until you know whether and how the patient wants to hear what you have to say. For example, some cultures prefer that family members, not patients, learn of serious illness or conditions first. And so know your patient's preferences. You may want to ask beforehand, before the tests are done, so that you don't feel awkward or uncomfortable when the results are available. I'm now going to spend the next few minutes talking about the use of interpreters in medical practice. I don't know why I keep saying malpractice. Fide, can you please put up the first poll question?
All right, so this question says, have you ever used an interpreter before in a clinical encounter? All right, and the responses were 80% said yes, and 20% of participants said no.
Okay, great. So I hope during the remainder of this session, I can provide you with some information about interpretation that might make it easier for the 20% of you that haven't done it before. And maybe for others who might be a little bit more comfortable in providing interpretation, please feel free to add in the chat some of the things that you've learned in your experience that you would like to share with those folks on the call that haven't had that opportunity yet. There are three main roles of an interpreter. So the preferred role is that of a conduit. And when an interpreter is acting as a conduit, they're rendering literally in one language what has been said in the other. There's no additions, no omissions, no editing, no polishing. The other roles are clarifier. This is when an interpreter explains or makes word pictures of terms that have no linguistic equivalent. And then checks for understanding. There's culture broker. This is an interpreter that provides a necessary cultural framework for understanding the message that's being interpreted. And then another activity categorized by the Massachusetts Medical Interpreter Association is cultural interface. So a cultural interface addresses recognizing and communicating the ways that culturally based beliefs affect the presentation, course, and the outcomes of illness, as well as perceptions of illness and treatment. So here's some guidance related to the use of interpreter. We've already discussed the federal guidance for providing language access services to patients with limited English proficiency. The best approach with patients who bring their own interpreter is to stress the importance that a trained staff interpreter is provided for their safety and their confidentiality. And if they'd still like to use their own interpreter, the provider should offer that the staff interpreter remain present just to ensure that both the patient and the clinician are receiving accurate information. There should be extra caution when a patient chooses a minor as an interpreter. Just thinking back to our case study with Miss Lean and her granddaughter Lisa, who's acting as her interpreter. Lisa was clearly an inappropriate choice for this role. She's just too young to understand the situation and too young to take on the responsibility of being an interpreter. Some states like California are working to pass legislation actually to prohibit the use of minors as interpreters. Additional information on interpreter services can be found at many state health departments. It can be found at the National Council on Interpreting in Healthcare, the American Translation Association. And then you can also look at websites of ethnic and cultural groups and even the embassies, as Dr. Leon mentioned during our last session. Language access services also apply to written documents and materials. And again, translated written materials aren't a substitute for oral interpretation. As you think about providing written materials in your office, please don't assume that your patients can read written language. It's possible that the patient's reading level may be lower than the level of the materials. So graphic-based materials can be a useful tool in these types of situations. And those can include the I Speak cards that we described during the last session, the Wong-Baker Faces Pain Rating Scale, and then the universal healthcare symbols that I mentioned last time. So the universal healthcare symbols is one of the handouts attached to this webinar, and it's also available on Moodle, and then the I Speak cards are also one of the handouts. Jose, I have another question for you. Other than the examples that are listed on this slide, what other materials do you think should be translated and made available to patients?
You know, it will depend on the services that you provide, but for health centers in particular, I am quite sure that the health centers may have the vaccine information statements, for instance, every time that they provide or they administer a vaccine. By law, you are supposed to offer information about the vaccine, the potential side effects, and what to do if you have a side effect. So those are materials that health centers may have or should have. And you can go to, for instance, the Centers for Disease Control and Prevention website and obtain those materials. You can go to the immunize.org website and obtain the vaccine information statements. You need to have information on other potential screening tests that you are planning to offer to your patients. Anything that is related to the main screening tests that health centers offer, like colorectal cancer screening. You know, there is still some difficulties offering the screening to patients and patient accepting, you know, the colorectal cancer screening, the breast cancer screening, and everything that is related to all these chronic medical conditions. You can get all that information from federal sources.
Great, thank you so much. Oftentimes there is some confusion between interpretation and translation. So when dealing with translated written documents, a best practice is to back translate. We talked a little bit about this last week. Back translation is the process where one translator translates a document into a target language, and then a second independent translator translate that document back into English, just to make sure that there's an appropriate meaning has been conveyed. Whether the document is in English or it's been translated into another language, you should also consider some additional aspects of written materials, writing in plain language, addressing low literacy levels, and then using graphics and pictures. So far, we've talked about the importance of using interpreters and translated materials in your practice. I'd like to now emphasize the importance of using qualified professionals for these activities. As I mentioned previously, some new standards have been published with regard to interpreters. You should take steps to ensure that the interpreters on staff demonstrate proficiency in both languages, have knowledge of special terms or concepts that are used by the person with the limited English or regional dialects. Research has shown that individuals with exposure to a second language, even those raised in bilingual homes, frequently overestimate their ability to communicate in that language. So just keep this in mind as you select interpreters and translators to provide language access services in your practice. You should also ensure that they understand confidentiality and they're clear about their role as an interpreter. One example of a role that may be inappropriate for an interpreter is acting as a counselor or a legal advisor. And then finally, that they can provide services in a timely manner. And timely does not have a specific definition, but you don't want to delay the benefits due to a patient. So if, for example, in a routine medical appointment, the health center should be able to offer interpretive services, but in a life or death emergency, it may not benefit the patient to delay services, right, until interpreter services can be obtained. So far, we've talked about the importance of using interpreters and translated materials in your practice. I want to emphasize the importance again of using qualified professionals. Phraseology is a set of expressions used by a particular person or group. I think I mentioned again the use of back translation. Ensure that materials meet community needs, reflect differences in dialect and cultural nuances, and are appropriate for the acculturation, education, and the literacy levels in the community. We're about to move on to the final module, which is speaking of culturally competent care theme. I just want to briefly summarize what we've just discussed in this module. Just keep in mind that attention to interpersonal communication is a critical aspect of culturally competent care. Interpretation with qualified interpreters should be used with patients with limited English proficiency, and then written material should be translated into the languages that are most common in your patient population. So now I'm going to pass it on to Fide. She's going to handle the final module.
All right, thank you so much, Saki. Give me 1 second. Can you see my screen?
Yes.
Okay, perfect. All right, so in this final module of this theme, we will highlight specific strategies for working effectively with interpreters. And more specifically, we're going to talk about the triadic interview. So I have one poll question, which is are you familiar with the triadic interview process? So give me 1 second. All right. If you can please provide your response. All right, so pretty much mostly all participants are not familiar with this process, so which is very timely that we're going to talk about it now. So although there are many variations of medical encounters using an interpreter, most share the format of the triadic interview. So in this technique, basically the provider, the patient, and interpreter all participate together. Beyond creating mutual understanding between the doctor and the patient, the triadic interview should also engender trust and ensure confidentiality. So the triadic interview begins with a brief meeting or pre-session with the interpreter. This allows you to establish ground rules with the interpreter, clarify the purpose of the visit, and set goals for the session. So in some cases, for example, during discussions about death and dying or the sharing of bad news, a post-interview meeting can determine next steps, clarify the interpreter's view of the meeting, and validate the interpreter's role as well. So next we will look at this technique more closely. So in the triadic interview, the provider should maintain control of the interview. The patient should interact directly with the provider, and the interpreter should manage the cross-cultural and cross-message language flow. So transparency is maintained when everything said by any party, including the interpreter, is interpreted in a language that others can understand. All comments, including any sidebar conversations that may occur, should be interpreted to ensure transparency as well. So a handout in your materials provides the triadic interview process, and you can have access to that handout in the handout section here. And more specifically, this is part of handout 2.4. So an interview checklist can help you. Here we have an example of the interview checklist, and this basically can help you prepare for a triadic interview and working effectively with an interpreter. So this checklist is provided in your handouts as well. And here are a few helpful reminders for this technique. First, you must be prepared that the triadic interview takes extra time because of the pre-session and the fact that everything has to be said twice. Also, the interpreter needs time to introduce him or herself to the patient, explain his or her role as an interpreter, and assure the patient of confidentiality. So during the interview, interpreters should interpret sentence by sentence. The provider should also speak slowly and clearly and avoid any jargon, as the interpreter will interpret all of the words he or she says. Lastly, patients should also answer for themselves, even if the interpreter is familiar with the patient in the case. All right, so we're now at the end of the theme, and we're going to conclude by viewing this video where members of an office practice how to convene a staff meeting to discuss providing better language access services to their patients with limited English proficiency.
Look, it's not that simple, Erin. We're not just dealing with a language barrier here. We're dealing with cultural issues, too.
How many visits does she have without an interpreter?
Look, We had her granddaughter there.
Do you realize the potential malpractice risks of not being able to communicate with a patient?
Never mind about the malpractice risk, Aaron. I'm worried about the human risks. This is a very sick woman whose granddaughter will be devastated when she dies. It's probably too late to save her even before she got here.
Malpractice, human risks, pretty grim way to start off a Friday.
It's Mrs. Leon. She refuses treatment or even an exam, but her daughter keeps sending her here with her granddaughter in hopes that I can convince her to do something. She's very sick, and she doesn't speak English. And we've been talking to her through her granddaughter and a neighbor, but I don't think it's working. And Aaron has been enlightening me about his opinions about using interpreters. I'm sorry. I just hate the fact that I can't even try to save her.
It's never easy to watch a patient waste away. And we all have those times. We all wonder if we could have done better. But we can't let the self-doubt paralyze us. We can still make things right. Aaron, do you know of any interpreter services in this area that might be able to handle Vietnamese?
You've never had to use an interpreter before?
Most of my professional life, I was the interpreter. Everyone always called on me whenever they had a patient they couldn't communicate with. I was the only one who spoke Spanish.
There are a few options for interpreter services that I can think of. One, with a little notice, we can get someone sent over from the hospital. Two, we can use telephone interpreter services. Three, there are specialized interpreter services in the phone book. We could also look at local Vietnamese organizations to see if they have any trained interpreters.
Let's do it. Rose, could you work with Aaron to try and find an interpreter? And Joan, I need you to call back Mrs. Leon's daughter and arrange for her to be here when an interpreter is available. I don't want phone interpretation. I mean, we all need to do this face-to-face and as quickly as possible.
Aaron, could you and Linda work with Joan to develop a protocol for the office so that we know how to arrange interpreter services for all our LEP patients?
While we're on the subject of limited English proficiency patients, we need to talk about the situation with Mrs. Gonzalez when she came in this week. I don't think she was treated very well at all. Just because she doesn't speak English well doesn't mean that she should be treated differently than other patients. I often hear people say that they think that people that live in this country should speak English. But we have a responsibility to all our patients.
Sorry to interrupt. I believe we are having some technical difficulties. Saki, we can't see the video, right? Is that?
Yes, I just got a message from an attendee saying that we can't see the video.
Oh, okay. Okay. Let me see if I can try to replay it again.
I don't have trouble seeing the video, but I think maybe somebody.
Yeah.
Did you?
Me neither.
You can't see the video, Jose?
No, I can see the video.
Okay.
Okay.
Yeah. I'm gonna share the link to the video and everything after the session. So I'm gonna continue playing it.
Patients, regardless of language, race, ethnic origin, or any other factor.
Well, personal beliefs aside, the fact of the matter is that the government requires healthcare providers to provide services in the language of our patients. We're the ones that need to speak their language.
I think that this is an important topic that we should set aside for an agenda to deal with next week. For now, though, we've got a long agenda to handle today. While we're on the topic today, though, I'd like to apologize to Dr. Rivera. I made a stereotypical statement to her about Hispanic women. I meant it as a joke. But she helped me understand that fostering stereotypes about other people is never funny. All of us can do better about how we treat others, even me.
plan to implement any of these strategies into your practice. And again, thank you all for your attention. I'm going to pass it to Dr. Leon. He will be taking over the Q&A session now.
Thank you, Fide. Just a recap of the video. This video is a good example on specific. This is an excellent example for all health centers about the quality assurance meetings that they must have by HRSA program requirements. It basically shows the conversation among the members of the team on how they need to address any of the issues affecting the services that they provide. The other great part of the video is that we need to remind ourselves about the need of conducting needs assessment in the community. We need to know we need to know our patients, what the needs are, if there is the need of interpreters, where we can find the interpreters, and work with community organizations to address all those issues. If you have any questions, please make sure that either you type your question in the chat box, or if you would like to ask your question, and use the raise hand icon and your line will be unmuted. In the meantime, I would like to remind you that we have all the handouts. If you go to the handout section, you can download the materials for this call, as well as you can also visit Moodle, and you can get all the information about this session. Sorry, Fide, can you just go back to the previous one just to also remind our audience that our next session is on November 10th, same time, 3 to 4 p.m. Eastern time. And if you would like to get the videos of the recording, again, you can either go to Moodle or you can go to our website, www.nchph.org. You can also get information about our upcoming activities, webinars, learning collaboratives. We are also hosting a learning collaborative on smoking cessation and how to establish a smoking cessation program. If you are interested, you can go to our website. We can also have a learning collaboratives on diabetes and webinars on diabetes, and we are going to start new activities on social determinants of health. All that information is on our website. Any questions in the queue, Fide?
I just wanted to, sorry, there was an error on the slide for the next session. Today is the 10th. It's our session 3 is on November 17th. Sorry about that.
And yes, Dr. Leon, we do have one question by Vincent Villanova. Should bilingual staff be certified in health translation? And also we have a very positive feedback by Carrie saying, thank you for a very valuable and informative session.
You know, it will depend on the state that you are in. Some of them require, that there has to be some kind of certification. But most of the health centers that we have conversations with, they hire interpreters, or they train interpreters from the community, and they are not by law, they don't need to be certified. But again, check the state laws. You can go to your either a local department of health or your state health department to get that information, because it varies from state to state. Any other questions?
No questions so far. No additional questions.
All right, just to clarify, our next session is a week from today, is on November the 17th. at 3 p.m. Eastern Time. So thank you so much for participating on this call. It's very, very helpful to get our staff and your participation and all the materials. And it's always such a great pleasure to have this communication with all health centers and all participants. Thank you and have a great afternoon.